Good evening, everybody, and welcome to this webinar. We will still wait a little bit for the people to gather. We are 250 right now, but still waiting for people. Hello, Gabriela. Hello, Damir. Hello, Simona. Hello, everybody. I saw Colleen. I saw Monica. A lot of people here. Welcome, everybody. Hello from Macedonia. Nice to hear from there. Hello from Hungary. Hello, hello, hello. Slovenia is here. Croatia is here again. Sweden, nice. Macedonia. Iran. That's very interesting. We also have somebody from Germany. And also from Bosnia. Hello, France. Switzerland. Hello, Anna. Macedonia again. We will begin in a few minutes, but still waiting a little bit for people to arrive here. Hungary again. Let's wait for the people. Oh, hello, Bulgaria. Hello, Italy. Croatia again. It's so nice that so many people from so many countries gathers together. Bulgaria too. We are almost 300 now and counting. Hello from Hungary again, and Bosnia again, and Bulgaria again, and Ploiești City, Romania again. Macedonia again. A lot of people from Macedonia, Hungary, Slovenia again. Yes, you're right. Let the party begin. In a few moments, we are going to start the party. Hello, Cluj-Napoca. Hello, Baia Mare. Hello, Iran. Already a few people from Iran. That's very nice of you. A lot of people that are passionate about endodontics. I really like that. Hello from Hungary. Hello from Macedonia again. Somebody says that it's a good beginning of weekend. I totally agree. Oh, Botoșani City from Romania. And Iași, this is the most northern part of the country. You are very close to Ukraine. Maybe somebody from Ukraine will be here also. Yash again, Slovenia. Welcome everybody. We are 300 now. I think we will stay 2 or 3 more minutes and then I will make the introduction. It takes a little bit because I don't think all the connections are made in the same time. And when I start, I want most of you to be as many as possible because I have some announcements to make in order that this presentation will go smoothly. So I think we will need most of you here. I will stop the webcam for a few moments. Don't worry, I'm still here. You will be able to hear me. I will be here. Something in order to improve the picture. In the meantime, we are more than 300. Petroshan, hello Anka from Petroshan. I love that city. Macedonia again, Galați, Hungary. you can see and hear me. Is that right? Thank you, Nicola. Thank you, everybody. Yes, yes, yes. I think we can start. We are more than 300 now, so I will start with some announcements for everybody. And the first announcement is that we have here with us this evening as an administrator of this presentation, Dr. Dariusz Miskiewicz from Poland. Hello, Dariusz. Say something to everybody.
To hear you, Dan, and it's a pleasure to participate in this webinar. During the meeting, some minor problems may occur, technical problems. So I just want to inform everybody that this webinar is recorded, and the link to this recording will be sent directly after the meeting to all registered participants. Thanks a lot, and enjoy the meeting.
Thank you very much, Dariusz, for for making this possible. So, as you all know, probably this webinar is organized by KaVo Care Company, and I officially want to thank them for offering us the opportunity to be together this evening. I hope it will be a nice presentation. I hope you will enjoy it. I hope you will be interactive. Let's establish some rules that will help us to be more efficient. Dariusz already wrote something in the chat, so please from time to time follow the chat, because if there are some technical things, Dariusz will make their announcements. And also, if you have questions for me, please write them in the chat. And also, if you have technical problems, also write them in the chat window, and for sure Dariusz will deal with them. I know that from time to time there might be some technical problems regarding the quality of the image. It's not about the presentation or about our organization, but it's about the platform, because as you probably know, always during this time, every day in this period, there are a lot of webinars, not only dental webinars. So I think the platform is overcrowded. So that's why I would kindly ask you to forgive us if something goes not so good. And as Dariusz already said, if you want to see some details, you will be able to have a better view on the recorded version of this webinar. Actually, we had this webinar on Wednesday this week, and it was in Romanian. It was for Romanian participants. And I could compare the two versions, the live one and the recorded one. The recorded one is much better. You will receive an email no later than 1 hour after this webinar. So if you want to watch again the webinar, please also check your spam folder in your email address, because a lot of friends wrote to me today that they cannot find the webinar on Wednesday, but the link was in the junk folder, and everything was fine in the end. And now that I finished with the organizational stuff, let's start the business. I will share my screen, and slowly I will start the presentation. So today is about endodontics. The presentation is called 10 Easy Steps Protocol to Predictable Primary Endo Treatment. And these 10 easy steps, it's not like I wanted to find a magical number, but this is how I managed to count these steps. I have to say from the beginning that even if I will talk about almost all the steps of the endo treatment procedure, I will focus at some moment about instrumentation, and especially about rotary instrumentation. But until then, until we will arrive to that chapter, I will say a few words about all the important steps that we need to follow in order to make a predictable procedure. The webinar will last for about 1 hour and 45 minutes. So as it's 15 minutes after 9 o'clock in Romania, we expect that at Romanian time we will finish about 11 o'clock, maybe a little bit earlier, maybe a little bit later. The Central European time will be about 10 o'clock. Once again, if you have questions, please write them into the chat window. I will try to have an eye on the chat window. If you see that more than 1 or 2 minutes passed and I could not see your question, please paste it again in the chat window. As it's possible, if there are too many questions or if I'm concentrated on some topic, it's possible that my eyes will not be directed to the chat window. So let's see how we will manage to pass through these easy 10 steps. And I will start with the first one. The first step is the case selection. And I could not say it's the most important, but it is as important as all the other steps that I'm going to talk about. And this step, the first step has, let's say, 3 different chapters or 3 separate stages. And we are starting with the consulting the patient. And the main thing that we will focus on, especially in this endo field, is the chief complaint. What was the problem that brought the patient in our office? And after we will find out what is the problem, we need to make some tests. We need to record some more data from the patient in order to have a diagnosis. And to put it in very simple words, this diagnosis means that we need to answer this simple question. The problem of the patient can be treated through endo procedure. And if we decided that it can be treated through endo procedure, the third question is that we need to be very honest with ourselves and to respond to this very honest question. Can I treat the patient? Do I have devices? Do I have experience to treat the patient? This is what we're going to talk in the next slides. I already see 2 questions, the same actually. If the Romanian guys could have access to the Romanian version of the webinar, guys, in the end of the presentation, you will have my contact data, you will have my Facebook page. And if you write me there, I can send you a link to the Romanian version of the webinar. I hope it will work. I think it will work. So just stay for that information. Or you can also write an email to Darius, and he will send you the link, which is easier for you. Okay, so let's see what is this problem with the diagnosis. I want to make everything very simple because it's a webinar. We are not in the dental office. We are not in a formal environment to an official lecture, let's say, with teachers or students. So I want to put everything in very simple words so you can apply all this information right immediately in your office. So what needs endo treatment? What diagnosis can be solved by endodontics? I started with this, even if it's not my favorite topic. It's endodontics for prosthetic reasons. I mean, we need to cover a tooth with a crown, and it is this old concept that if you place a crown on a tooth, then that tooth, one idea would be that the tooth will follow an endodontic procedure, which we know that nowadays this information is not true anymore. Actually, the endo treatment should be reserved only for those procedures that when you prepare the tooth, you open the pulp chamber. If you don't open the pulp chamber, even if we have a very thin layer of dentin, the recommendations are today that we have materials, we have devices, and we have skills to preserve dental pulp. And the best thing for that tooth, we know that from many points of view, is preserving dental pulp as long as possible. So I just only want to make one comment, because I'm sure that you met this thing in your day-to-day practice. Sometimes it happens that you place a crown, and after 1-2 weeks, or maybe 1 year, or maybe, I don't know, 6 months, some patients return to your office with pulpitis, and they experience pain, and we have to explain them that we need to perform an endo procedure. And of course, the patient will honestly ask the following question: why didn't you make the endo treatment before you place that crown? So I think that the correct way to approach this situation is that even before you touch that tooth with the first burr in order to prepare the tooth for placing the crown, you need to have an honest discussion with the patient and to explain the patient that the best way for his tooth is that the pulp will stay there as long as possible. But sometimes it happens that teeth that were prepared for receiving crowns will develop pulp inflammation, and then endodontic treatment should be performed. And in this situation, we have now technology to make the endodontic treatment through the crown, no matter the material the crown is made of. So we have technology and skills to make the endo through the crown and then fill the coronal cavity, so that nothing will do to manage the future of that crown on the dental arch. If you have this discussion before you started to prepare the tooth, that would be a very honest way. If you don't have this discussion and some patient will come back with pulpitis, then the patient will be entitled to believe that if you make a hole through the crown in order to resolve his problem, to solve this problem, the pain generated by the pulpitis, you will try to repair something that you did wrong, but without changing the crown, I mean without reducing your costs, which is not medically true, but this is what the patient will think. So that's why I think you should have an honest discussion from the beginning and explain the patient what will be what will come next and what can happen bad. And if that happens, then we should discuss from the beginning what are the solutions. Marian tells us that it's better to sign an agreement. Of course, we have to make some papers. Anytime we make a dental procedure, a medical procedure, we need a consent, an informed consent, and it's better that you place in that consent as much information as possible. The second one, the most common one, and this is of course nobody can contradict this bullet. It's irreversible pulpitis. When you have irreversible pulpitis, then it's time for endo. The same with pulp necrosis. If you detect pulp necrosis, the only solution for that tooth is to perform endodontics. The only difference between those two is that usually pulpitis hurts, patient experience pain. That's why he comes into our office. While during pulp necrosis, usually we discover that accidentally, or maybe patient at some moment discovers that the color of the tooth is changing, so he asks himself, and then he asks us what is going on. And the last one, remember the last one, so we don't have 1,000 possibilities, we don't have even 10 possibilities, we only have 4 possibilities, and the fourth one is the apical periodontitis, but not any kind of apical periodontitis, but bacterial induced apical periodontitis. So these are the 4 situations when we need to perform conventional endodontic treatment. Of course, we can talk about trauma, but we should try to put these trauma cases in one of these 4 situations. I mean, opening the pulp chamber while preparing the tooth, or a traumatized tooth that developed pulpitis or pulp necrosis, or even worse, apical periodontitis. Otherwise, even if we have a trauma and that trauma opens the pulp chamber, we know that nowadays there are solutions that we preserve dental pulp as much as possible. So we need to do everything to preserve that dental pulp. And I will not continue more on this topic. Just I want you to judge yourself and to understand that this information that I gave you today comes from a person that actually earns money from endodontics. And primary endo and this endo for prosthetic purpose are the easiest cases for us. So we, the endodontists, would be very happy if we could only treat primary endo for prosthetic purpose, because patient comes with no pain, there is no emergency, usually anesthesia works fine, so we actually have nothing to face during the treatment, no difficulty during the treatment, or almost no difficulty during this treatment. Somebody said that can I give an example for non-bacterial induced apical periodontitis? Of course, trauma, occlusal trauma, chronic trauma on the teeth can generate apical periodontitis, not bacterial one. Or if we do an endodontic treatment, after the treatment, you know that the patient can experience pain for 1-2 days, maybe 10 days, it depends. That is apical periodontitis. But it's apical periodontitis that may be generated by mechanical trauma that we do with the files or with the material of the root canal filling, which can be mechanical but also chemical trauma. So these are apical periodontitis that we do not treat by endodontics, by treatment or endodontic retreatment. This is trauma that either they heal by themselves, or we need to do some other procedures. If we talk about occlusal trauma, then we need to adjust the occlusal contacts in order to fix this problem. And if we decided that we are in one of these 4 situations that I mentioned, then we need to establish if we are the ones that are entitled to treat that patient. And in this perspective, we need to be able to auto-evaluate ourselves. And I placed this American Association of Endodontic guidelines just in order to make you an idea about how you should judge your case and your ability to treat, or the need to refer that case to another dentist that has more experience, or maybe more devices in his office, and he can more safely address to that case. But these are only some recommendations. You see that they recommend to divide the criteria into categories. For example, we are talking about patient considerations that are the general health, of the patient. Then we talk about the diagnosis and treatment difficulties, considerations, and some other considerations, like, for example, trauma that I talked about, or if it's a retreatment, or the whole history, or if there are some other pathology, like periodontal pathology that is concomitant with the endodontic pathology. So these are some guidelines, and if you want, you can find these guidelines on the site of American Association of Endodontics. But the idea is not to copy as it is, but to adapt to your practice and to your skills, and of course to your patient profile that you treat in your offices. And I will only give you one example. I don't have time to discuss any line of this table. It's the red circle. I don't think you can distinguish what's written there at this resolution, but I will tell you it's on the middle column. That means it's a moderate difficulty criteria, and it says simple pretreatment modification required for a rubber dam isolation. That means in translation, it means that we construct the lateral walls of one tooth in order to be able to place the rubber dam. And in my case, as you will see further in the presentation, that never happens. I always place rubber dam as good as possible. I would say almost perfect. And then I construct the lateral walls. I will never make the walls in order to be able to place the rubber dam. Because if I do this, I know that I place some composite in some not very perfect conditions on some walls of the tooth that are immediately near the gum or even under the gum level. And if I do this, I know that I can't trust that adhesion, and I will fool myself, or I will fool the colleague that is going to restore that tooth, because that wall that I constructed will not be a long-term solution, because I know there is no good adhesion. I could say that actually there is no good adhesion or bad adhesion. You have adhesion or you don't have adhesion. And in that case, you just don't have adhesion. So I can't use this criteria. I can only use the first column and the last column. And the last column refers to complicated procedure in order to be able to place the rubber dam. And that means you act surgically. You make gingival and alveolar modifications, which is alveoloplasty, or you do orthodontics extrusion, which is also something more complicated than just reconstructed some walls. So that's why you should adapt your this form. You have to adapt it to your day-to-day needs. The third step. So you remember we were talking about case selection. The second one was isolation with rubber dam. The third one is proper anesthesia, and we know that in most of endo cases we need very good anesthesia. I would say that even in non-vital teeth, very often we need anesthesia. Actually, in my case, it happens always that I perform anesthesia in the beginning of the treatment. There are only few situations that I don't do that. And I do that because I know that starting with the rubber dam clamp and finishing with vertical compaction with hot instruments, I can generate pain, and I don't want the patient to associate the endodontic treatment with the pain. So that's why I want proper anesthesia, and I want more than that. I don't want that my patient experiences pain during anesthesia. So I train myself every day to deliver anesthesia without pain. That doesn't mean that I use some contact anesthetic. I don't believe in that. It's more about the procedure than the contact anesthetic, that the surface anesthetic that you may use. But this is another story, and we don't have enough time to talk too much about it. We need to choose a substance. I will tell you about my choice that doesn't really necessary to be your choice, but I will justify why I always use articaine with the most available, the less available, sorry, the less available vasoconstrictor substance, because in this case, usually vasoconstriction is not so helpful for endo treatment. We know that a good anesthetic can last for about 4 hours without such a big quantity of vasoconstrictor. And what we know is that the vasoconstrictor in the anesthetic actually limits our maximum allowed anesthetic carpula that we can introduce in the patient. So the maximum dose is limited not by the anesthetic itself, but by the vasoconstrictor substance. So as I don't need so much vasoconstrictor, and I know that I might have complications about that vasoconstrictor, I prefer to use something that has less vasoconstrictor, but allows me to have a higher dose of anesthetic if needed. Also, proper place, it's a very important thing, because many of us, and I recognize that in front of you, many of us try to avoid the palatal anesthesia, because you know that the palatal anesthesia is quite unpleasant for the patient. And I told you that I don't like to cause pain to the patient, so we need to train a lot in order to deliver this anesthetic without pain, even on the palatal side. But we need to also know that very often when we treat vital teeth in upper jaw, we really need to use also anesthesia in the palatal side. And yes, there are situations, and they are not very rare situations, when actually we need more than conventional anesthesia. That's why I placed this electronic delivery system. Sometimes we need to be able to deliver intraligamentary anesthesia, or even intrapulpal anesthesia, which is actually the last weapon that we have in order to be able to deliver the endodontic treatment. But please do not make use of intrapulpal anesthesia if you can't open the pulp chamber painless. I mean, yes, there are situations when you cannot do endodontic treatment because you don't have enough anesthesia, but still you should have enough anesthesia so you can open the pulp chamber with almost no pain, or with no pain from patient side. And if you succeeded to open this pulp chamber, then you need to make a very, very, very small orifice in order to be able to properly deliver this anesthesia. Because actually, as you probably know, intra-pulp anesthesia is more about pressure and less about substance. So if you just rinse the pulp with anesthetic, you will not get the anesthesia. You need to be able to create pressure inside the tooth. So that's why the opening of the pulp chamber should be as small as possible, and you should be able to deliver as much anesthetic as possible. I'm just making a break in order to watch to the chat. I like that you talk to each other, and you are discussing about, we are talking here. Darius says that links will be automatically sent to you. We mean the English version links. And Darius said that if you want the Romanian version, you can write him, or you can write me, and we can help you with that. But don't we make the endodontic build-up temporary, asks Alexander. Yes, you can do it temporary, but then you have to think that somebody after you, or even you, if you are also the prosthodontics, should do something. So should remove that, and then should reconstruct those walls. So in the end, we need to make adhesion on those walls, which can't be possible made without rubber dam. So as I've told you, once again, it's useless to make some walls in order that somebody will destroy them, and then that somebody should be able to do the same thing that you should do even in the beginning of the treatment. So that's why I was talking about that, and I insist that you as endodontists need to be honest with you, with patients, and with the referrals. And if you can't isolate that tooth in order to make perfect adhesion for the lateral walls, trust me, you are the most experienced in this game with the rubber dam, because you use it routinely. So if you can't place rubber dam, nobody can do that. Nobody is more experienced than you. So as the other doctors, the other dentists will continue the procedure, the prosthodontic procedure, they will cheat on their patients. So my advice is never start a procedure if you can't do perfect adhesion on that tooth, with or without help from surgery or from orthodontics. That's not a mistake to wait until you have orthodontic extrusion, but you need that in order to have proper isolation. I do always. If you don't, it's hard to close the tooth if you need to place calcium hydroxide and temporary closure. Yes, of course. So I exposed my reasons about that. I will just stop for 1 second. I just want some feedback from somebody, from some of you. What about the sound? Can you hear me? Okay, so if you understand me, I know that the quality of the movies, it's not the best, but if you can hear me, then this is the most important thing. Let's go further. We are talking now about isolation itself, and I've already told you about that, and you have here an example. On the left side, on the right side, you have a movie, and the movie is not continuous, but it shows how in the end, after I made the root canal treatment and the root canal filling, now I'm reconstructing the tooth. But that's not the most important thing. The most important thing is that if you look into the left photos, then you can see that even from the beginning, I struggled to place the rubber dam so that I will not have any trouble during the treatment. And if I did that with the walls that I have, and with the deepness of the pulp chamber, I can do the endo procedure even without reconstructing the buccal wall that is missing. As you can see, I have enough place in order to have a sodium hypochlorite tank, like a buffer, so that I don't even need to reconstruct that all before the treatment. But as I told you, if you look into the lower image, where you can also see the root canal filling and the isolation, you can see that everything is perfect there. So as I told you, I'm sure that I will have the best adhesion that I can deliver. If we are facing with hooked or curved palatal root, first to use palatal, yes, we need to use palatal injection. If I used brinker clamps, yes, it happens that I need brinker clamps, but the problem with the brinker clamps is that usually they don't stay as themselves on the teeth, because if the tooth is so destroyed, the brinker clamp will be effectively thrown out of the mouth, because the rubber dam sheet is elastic. So in that situation, if I have teeth that are distally situated relatively to the tooth that I have to work, then I will use multiple clamps. So I will place a clamp on a tooth that is distally located, and then yes, I can use that brinker. My opinion, if reversal post is a must, I will talk about that in the end of the treatment. Please, my friend, if I don't, if you are not satisfied with the information that I give at that topic, please repeat that question, or please make it even more clear for me, but I'm sure that I will cover that subject in the end. Regarding the pulpotomia, I already said I am a conservative guy, so as long as you can conserve some pulp, as you can keep it there, you should do the best to keep it. But if just take also in consideration that if you remove the whole pulp of the pulp chamber, and more than that, if you cover that tooth, you will have no way to test that tooth anymore with the cold or electrical tests. So you have to inform the patient that you will have to take periodically some x-rays, and if it experiences pain, or if you see something on the x-ray, that might be the sign that you need to perform the root canal treatment. Otherwise, I've told you, as conservative as possible, because it's about resistance. If you will see, if we do endo treatment, we weaken the tooth structure, and that can be not so good for the tooth. So let's go to step number 4. It is about proper access cavity, and I'm sure you will have a lot of questions here, but please wait until the end to finish my ideas about access cavities. And then if you have questions, I will of course I will ask to all of them. So the proper access cavity is not actually the cavity that we learned when we were students. I don't want to criticize those information, but I just want to make myself clear. One is the information that you receive when you are a student and you don't know anything about, I don't know, tooth architecture, or you know it but only from books. You did not open any tooth to see what's inside. And the other way, another way you think when you have, let's say, 20 experience of dentistry, 20 years experience, and you know what you can do actually and you cannot do. So you can see in this slide 2 different approaches. On the right side, it's an extensive access cavity, is very close, or it's even wider than the book teaches us. While on the left side, you can see a minimally invasive access cavity, which is good and which is wrong. Actually, both of them are good. And I think the access cavity is more about you and less about patient and tooth. You have to take in consideration the patient and the tooth, but I think the shape of the access cavity and the how great that cavity is or how small, it's only about you. If you are experienced and if you have access to x-rays or even CBCT, then you can make some decisions when you can make small access cavity and when you need to have a larger access cavity in order not to produce accidents when you treat your patients. So my advice is to adapt, to adjust the access cavity to your skills. And of course, your skills improve with every patient that you treat. They improve with every single case. They improve daily, they improve weekly, and they improve with the years that you practice. And of course, teeth that today you will treat with a large access cavity, which, by the way, it's not wrong, because if you make the access cavity too small, if you do it too small, you can create other accidents that are more dangerous for the future of the tooth on the dental arch than the large access cavity itself. So this is my advice. I can't give you some rules, but still you need to know the theory from the books that you studied in university, and you really need to understand the principles that generated those rules. So you need to know why in that book it's written that the access cavity of the central upper incisor should be triangular shape. Of course, in real life, it's not like you draw a triangle on a sheet of paper. But if you understand what the author meant by that triangular shape, then you can adapt that. You will understand with your experience that in older people, usually we need not so extended access cavities, while when we have young patients, if we are not so experienced, we need large access cavities in order to be able to clean the whole pulp chamber. And that's only an example. Another question is, after we perform endodontics through porcelain crown, if we need posts. Please repeat this question when I will talk in the end about step number 10, because step number 10 I will anticipate, and I hope that most of you will resist with me until that time. So the step number 10 will be reconstruction of the tooth, and I will tell you my philosophy about that step. Now we are at step number 5, and we go down and down inside the root canals. Now we need to identify all main root canals, and please remember this word main root canals, because you know that anatomy, dental anatomy, and endodontic anatomy is very complex. So we have main root canals, and we have a lot of other kind of canals, like lateral canals, accessory canals, isthmuses, and something like that. So first of all, we need to identify all main root canals. And if you succeeded that, then we go to the following steps. But we need to be able to identify all these main root canals. And we know that first rule is to have a proper access cavity. And I explained you what means, in my opinion, a proper access cavity. If you finished university last year or maybe last month, of course you need to see more. If you don't have loupes, or if you don't have dental microscope, of course you need to open the tooth more in order to better see what's going on inside. So generally you can guide yourself even with the dimension of the access cavity, in order to be able to identify all these main root canals. On the other hand, we have some maps, and you learn even from the university, you learn that if you have a multi-rooted tooth like the molars, then when you open the pulp chamber, if you are careful enough not to destroy what is on the floor of the pulp chamber, then you can easily see what you can see in the two images on the top of the slides. I mean, you can see those grooves that starts from one root canal orifice and goes to the other one. So this is how actually you can identify even the most difficult root canals to identify. And you can identify like that even calcified root canals, and you can do that even if you don't have dental microscope. But what I don't recommend you, if you don't have magnification, is not to try to dig into that calcified root canal, because even if you are sure in the beginning where the orifice was placed, as far as you go inside the root canal, your possibilities about seeing and understanding what's going on there are very limited. So this map on the floor of the pulp chamber can guide you, but even if you see that there is a root canal, if you can see that it's calcified, sometimes it's better to leave it like that. And there is nothing wrong to inform the patient that you saw it, you know it's there, but you saw the barrier, the calcium barrier, so you leave that canal like that. And if in future something goes wrong, maybe that patient should see an endodontist. It's not a wrong approach to send directly the patient to the endodontist, but the problem is that the patient will pay some money, and not quite a small amount of money, and maybe with that root canal with vital pulp inside, the patient could stay maybe 10, maybe 20 years, maybe the whole life. So if I were a general practitioner, if I have a calcified canal and I'm sure it's a calcified canal, I can see the place where the orifice was at some moment and now it's completely blocked, I will not immediately refer the patient to an endodontist, but I will just explain the situation, and together with the patient, I will monitor the case. Of course, the pictures on the top of the screen looks that the cases are quite easy, but if you will talk at the bottom of the screen, you will see a particular situation. It's a premolar with 3 root canals. And in this situation, actually, maybe on the X-ray you can see, or you can think that there are 3 root canals, even if you don't see them perfectly. But the opportunity to find all these 3 canals and to instrument them, it's not for everybody, because as you can see, usually in this situation, if you look in the middle, in the image in the middle, the orifice of the 3rd root canal, usually it's inside the 2nd one, and it's not in the coronal 3rd, but usually it's in the middle 3rd. So this is not an easy case. And once again, if you detect this from the beginning, and if you find a 3 root canal premolar, this time I think this would be a fair way for you and for your patient to send the patient to an endodontist. If you don't see it on the X-ray, actually it's impossible for somebody that does not have magnification, it's impossible to find it during the procedure. So probably you will miss it, and probably if you work correctly, nothing will happen. But if you don't respect all the rules, and the first rule that you should respect is the rubber dam, if you don't do that, maybe the patient will experience some problems at some moment, because some bacteria may leak inside that root canal, and then you will have to address the patient to an endodontist. We have some questions here, so I will stop a little bit. Miha asks me if I use CBCT for canal anatomy. I use it, but not on every single case. We have to understand that X-rays and computer tomography are invasive investigation methods. That means that we use some dose of radiation, not so big from somebody's point of view, but still there is some radiation that we put in our patients. And I recommend to do these investigations only if we really need them. This also comes also with your experience, but no, I don't think in the nearly future this approach to have for every single tooth a CBCT scan, I don't think this should be a good approach. Regarding the digitally endo guides, no, I never did that. I do it, but I do it only for show. I don't think I really need it at this moment, but this might be the future if we will be able to bring into this field more and more stuff, like, for example, instruments to be able to clean and feel the teeth through very, very, very small root canal orifices. Otherwise, I don't think we really need that. Somebody asks me if I use endomicroscope. Starting from 2006, every single treatment that I perform, I do it exclusively under microscope. And even if my practice is limited to endodontics, I can't hide the fact that it happens sometime that I need, after endo treatment, to place a provisional crown on an anterior tooth because the patient can't leave the office without a tooth in that region. And if that happens, all the procedure is performed under rubber dam and with microscope. So I can't live without this microscope. I worked for 2 years almost, actually 1 year and a half, and maybe 2 years during university without magnification, but I don't think I can return to that because my brain cannot imagine that what my eyes see is good enough, is great enough in order to perform the procedures. So yes, I always use endomicroscope. How can I clean the floor map after use of aggressive canal detector? Peter, I think if you use very, very, very high quantities of sodium hypochlorite, you can do that. Actually, I don't use this caries detector because I don't need something like that with the magnification and the experience that I have. But I used to use this substance in the beginning of my career, and the sodium hypochlorite is strong enough to clean the pulp chamber floor. So I don't think any difficulty you will encounter during this procedure. Somebody, Wana, asks what is a digitally endo guide. Wana, I think you know that there are some guides that you can use in order to place dental implants. They are used either by the beginners in implantology or by very experienced dentists, but they want to make the procedure very, very precise. The same is nowadays available in endo. You can make some guide that you do the access cavity through this guide, and you plan everything in advance on the computer, and then you have a guide that does not allow to the drill to go to the left or to the right. The problem is that sometimes it's difficult to predict exactly where the pulp chamber floor is. So if you are not experienced with that, even this could turn in an accident because you can perforate the pulp chamber. But for the average dental cases, you can use these guides in endodontics, but I think it's too much effort for less, let's say, less gain that you achieve. What type of burr do you use to excavate the caries and finding of the canals? Actually, I use two kind of burrs. There are the high-speed burrs, which are always diamond burrs, and I use them both in enamel and dentin, but always with cooling agent, I mean with water. Never use these burrs without cooling water. And in altered dentin, in affected dentin, and sometimes in when searching for root canals, I use low speed burrs. These are steel burrs, and I use them in normal speed when I cut affected dentin, and I use them in very, very low speed. I mean no more than 1000 rotations per minute when I'm trying to detect root canals. I mean to dig into dentin for the calcified root canals. But I don't use dental burrs. I don't always use dental burrs. Usually we use, for digging into calcified root canals, usually we use ultrasound. I will show you the ultrasonics a little bit later for something else, but it's the same device. When you put the rubber dam, yes, always before starting the preparation. I don't think something will change so much if I do it later. But rubber dam offers some advantages, and the first advantage is that it keeps the cheek and the tongue of the patient far from the working field, and this is the first advantage. I mean, not the most important, that the first advantage that you get during the whole dental procedure. So I always place the rubber dam in the beginning. I know that there are books and there are authors that recommend to place the rubber dam later, after you made the access cavity, because their argument, their reason is that when you place a rubber dam, you may create accidents, because actually you are not no more aware about the direction of the tooth, and we have very inclined teeth or rotated teeth, and that can cause some damage. My opinion is like that, and I will finish this subject because it's quite late. I will kindly ask you not to be upset if we will stay a little bit longer. I'm very glad that there are a lot of questions. I will try to answer all of them, but you have to understand that it will last a little bit longer than expected. So let's continue. If we face that situation, that the position of the tooth is modified, then we have two solutions. The first solution is that we isolate not single tooth that we used to do in endodontics, but we place the rubber dam on 2 or 3 or maybe 4 neighbor teeth, in order to have a better view to the whole jaw, or the whole part of the jaw in that region, so we can appreciate the tooth direction. Or the other way, and I believe in that way, is that we really need to look very careful of the tooth before we place the rubber dam, because trust me, somebody that realizes that it's something wrong with that tooth and that he needs to be careful when he prepares the access cavity, that somebody can do it with or without rubber dam. But if there is somebody that will fail with the rubber dam, I'm sure that that person will also fail without the rubber dam, because the reason of the failure is not the rubber dam, but it's the fact that he was not careful enough in order to analyze the position of the tooth. And if you realize that, you can act accordingly, I've told you, with or without rubber dam. And we know that it's better to open the access cavity when rubber dam is already placed. Thank you, Damir, for your help. I'm very okay with that. I also know that we have from the care company, we have representatives here. There are many, not only Darius, that is actually the administrator. So if there are questions during this presentation that are related to KaVo care products or with the procedures, and you think you can give advice, please, everybody, feel free to comment. Hello, Josip. I say hello to you. I hope we will be able to meet again sometimes. I didn't know you will be here. I'm very happy to hear that. Let's go further in the presentation. Now we arrived at step number 6, and from my point of view, this is the most important for the final result of the treatment. If we agree that one important thing is to clean the root canal on its whole working length, and if we agreed that it's necessary to do that, then this catheterization is the most important step. And as far as I've noticed, this is the step where many of my colleagues encounter difficulties. So that's I will stay a little bit on this slide, and I will try to explain some simple principles. And if you follow the rules that I've told you, maybe you will get good results easier than you managed to get them now. But first of all, because we are going through a protocol, and now, up to now, I think what I said cannot be, let's say, debated too much. Of course, maybe there are some small details that we can discuss, but I don't think what I said until now can be highly debated. While starting from this moment, I think we go into a field that it's very large, and there are so many recipes, good recipes in these steps that will follow, so that it's impossible to me to cover the subject completely. And what is the most important is that you should understand that what I give you today is a simple protocol, but it's just a protocol. I can't say it's the best. I don't think there is one single best protocol, but this protocol is based on my experience as a dentist. And of course, we all started from the beginning. Nobody was born with some endo skills and some endo knowledge inside his brain and his hands. So we all started from the beginning. So this protocol is based on my experience as a dentist, and also as a key opinion leader and as a lecturer. And I gave a lot of hands-on lectures for dentists and students, and I tried to understand what are their difficulties. So in my opinion, this protocol, which once again, I don't think is the best and maybe not the easiest one, but this protocol in most of, in the hands of most of our colleagues will work. So you can take it, you can adapt it, you can improve it, or you can say, I'm too advanced for this protocol, but still you have my reasons for which I see the things the way I will present during next slides. So let's get back to the catheterization. There are some simple rules, and I will talk about every single detail that I consider important in this step. And the first detail is that we need stainless steel files. You can't do catheterization on difficult cases, I mean really difficult cases, and you will see what does that mean. You can't do this with nickel titanium hand files. Then the second thing is that these files should be curved, not excessively curved, but curved. They don't have to be introduced straight into the root canal, because if they are straightly introduced, then unfortunately they can cause accidents, and these accidents are ledges or perforations. The third thing that you need to have in mind is that always you need a lubrifying substance, and this lubrifying substance is not EDTA as we were used to think, let's say 10 or 15 years ago, or maybe 100 years ago, but this lubricant should be sodium hypochlorite. Always your pulp chamber should be filled with sodium hypochlorite. And if you do that, your files will be lubricated enough to be able to catheterize even the most difficult root canals. So let's repeat what we have up to now. We have sodium hypochlorite in the pulp chamber, we have stainless steel files, and we have curved stainless steel files. By the way, I hope everybody knows the difference between curving and bending files. One means to bend the file, and it's totally something else to curve them. There are even special instruments that you can use to curve the file in order not to bend them. If you think you need them, just use them. I never use them. I just use my fingers to curve the hand files. But of course, this comes with your experience, and of course with your preferences. One thing about me, because I did not want to lose too much time to present myself, I think it's most important to see how I'm thinking from the endodontical point of view. And one of my concepts is that to keep everything as simple as possible. And here I'm talking first about the dental materials and instruments. If we can do something with simple or with less number of instruments, we should approach that stuff. Yes, thank you, Kamir. Thank you, Kamir, for helping me with the comments. Thank you, Damir. Let's get back. So we have 3, and now we will go to the 4th, and this is also very important. Damir already said it's about watch winding movement. As you can see in this movie on the screen, on this animation, this watch winding moving is like I think you can see my webcam. So if you look to my fingers, it's just the movement that you use when you put some salt on your food. Uh, of course, watch winding means something connected with old watches, but as we have a lot of young people here, I will not talk about mechanical watches, which, by the way, I like and appreciate very much, but they are not so popular anymore. So maybe some of you don't know about this watch winding, what means, but I think everybody would use salt. And this is the movement 30 degrees clockwise and 30 degrees counterclockwise while moving this file. So if you have these 4 rules in mind, you need to remember that you will never, but never encounter an obstacle, a barrier inside the root canal in the apical third. And I make that state because very often I'm talking with colleagues that say, okay, I had a very difficult case and the canal was calcified in the apical third. That's impossible. I mean, not impossible, but it's a very rare situation. And I will tell you when that happens, when you can find a completely calcified canal in the apical third while you have been able to instrument the root canal up to that level. You will never find that situation on primary cases. You will only find it if somebody else treated the tooth years ago, maybe when the patient was a child, and he treated the tooth as conservative as possible. I mean, he left some pulp in the apical third of the root, probably not because he was not able to treat the tooth, but maybe because he wanted that pulp to stay there and to contribute further to the root formation. And that's the only situation when we have vital pulp. We had vital pulp inside the root canal, actually only in the apical third of the root canal. And during years, that pulp could calcify completely the root canal. But I'm sure almost nobody will encounter that situation during the whole career. So let's stay in the usual parameters. When you feel something like a block, you try to instrument the root canal and you feel that you use a very, very thin file and you hit something like a block, that is not calcium, that is not something calcified, that is not a blockage, but that is a ledge that you started to dig. And if you will continue, probably you will produce a perforation. So what is the solution if we encounter that problem? The solution will be very easy to understand if we accept that root canals are not straight. You can see in this animation that I stopped now that we have very, very many curvatures. I can count 5 or 6 curvatures on this animation, and this is not science fiction. This is actually real life. So there is one more simple rule, that in order to be able to address the apical curvatures, we need to get rid about the coronal curvatures. And when I say get rid, it's not really necessary to completely straighten the root canals, but we need to straighten a little bit the root canal in order to be able to access it further. And I will try to create a drawing. I hope it will also work on your screens. Actually, we will need to do something like that. And imagine this, that is completely red. I mean, we enlarge and straighten the root canal up to 1 point. And when we do that, we will be able to address to the further curvatures. And I will describe you how exactly we will do that. Let's suppose we have a tooth that we estimate, let's say 20 millimeters working length. And we try to catheterize, and we see that at about, let's say 17 millimeters, the number 6 file, I mean the most thin, the thinnest file that we can have, it blocks. It digs into something that is strong. That means we are starting to create a ledge. Well, remember that is 17 millimeters and we need 20 millimeters. What are we supposed to do? We will take thicker and thicker files like number 8, 10, 15, maybe 20, sometimes maybe 25, and we will try to enlarge the root canal not on 17 millimeters, but to 16 or maybe 15 millimeters. So we will stay shorter, and after each single file that we use, we irrigate a lot, and then we take the number 6 again. We check that it still goes to 17 millimeters without forcing further. And you will be very surprised to notice that at some moment, without doing nothing more special than enlarging the root canal to 15 or 16 millimeters, at some moment you will feel that the number 6 will go by its own further. Maybe not till the apex from the beginning, but you will gain 1 or maybe 2 millimeters. And you will do this step by step until you will be able to access the whole working length. Please do not forget that you need to recapitulate, I mean to rinse, and then to take the number 6 instrument and to ensure that you do not create a plug into the root canal, because if you are doing that, you will be even shorter than you were in the beginning. And one more advice here, and I will finish this slide. Actually, I will erase the ink, and then I will leave it play again. It will start playing again now, probably. The final information that I want to give you about that is what happens if you really, really, really cannot go further. Have you any suggestion about machine instrumentation? Are you talking about catheterization or the instrumentation, meaning enlarging the root canal? I will look further to your comments. Once again, what happens if you cannot go further? So there are two situations. You stop immediately and you send the case to an endodontist, but you stop immediately. You don't try and try and try for many hours, or you stop, you irrigate to that working length, you enlarge the root canal to that working length, and you fill the root canal. And if I am to give you an advice, I would advise you to adopt the second choice. I mean, if you cannot reach the working length, just stop where you can, because most of the cases will be vital in this situation. And if you cannot reach the working length, you may have the chance that you will have an ugly X-ray. It will not look good at all because you will have a very short root canal filling, but the pulp that stays inside will be vital and probably not contaminated because you used rubber dam and you use sodium hypochlorite in order to irrigate. So actually, why do I advise you to do it like that? Because if you insist to clean, then you will create smear layer, and I will later talk about this smear layer. So if you create this smear layer, then with this debris, you will make a plug into the main root canal while digging a ledge into the lateral wall. And if you do that, even the most experienced endodontist may not be able to fix the case without periapical surgery, because everything is blocked there and everything is tough. When you try it with the files, you only feel something that is very, very tough. Doing that will generate further debris, further smear layer, and you will dig more into that ledge, and finally you will succeed to make a perforation. But what if you don't do anything and you just rinse and you leave it like that? Imagine that there are main root canals, and of course, you know, and I will show you immediately, there are also lateral anatomy, lateral canals. What do you do in your daily practice with lateral canals? Do you instrument them with files? Of course not, because you don't even know that they are there. Maybe you will find out they are there when you see the root canal fillings on the final X-ray. But you don't instrument, you do not enlarge these canals. What you do instead is that you clean them with sodium hypochlorite and with ultrasonics. And this is what I advise you to do with this apical dental pulp. Just imagine this, just pretend that it's a lateral canal. It's like a lateral canal. You cannot instrument it. Try to rinse and to use ultrasonics in order to clean as much as possible. And if you will do that, I ensure you that you will have no problem with the success rate of your cases. But I've told you, if you insist, maybe you will block the root canal and you will transform this case in something impossible to be solved, even by somebody with very, very strong experience in this field. My suggestion is to treat what you can and to inform the patient that at some moment, if there will be complications, you will refer the patient to an endodontist. And now let's get further to the stuff with the working length. This is a topic that I like very much, and I don't know how clear you can see the movie, but I can imagine that you see the apex locator and you saw the clamp of the apex locator. What I mean is that always we should use electronically determined working length. What you can see now in the movie is that we have a ruler. I love this kind of rulers with those orifices because they are very fast, and I don't really need to use the scale. Just I will introduce the file in one or two holes and I will see approximately what the length of the root canal is. And it's very easy to communicate with the dental assistant using that ruler, because if I will use the scale, I will measure the file, the dental assistant will measure the files, and probably because there are two different operators, the length will not be exactly the same. And what is very important is as soon as you know the working length, just tell the assistant to write it down on a sheet of paper or in a computer. If you have a software for that to deal with that, just register the working length, and you don't need only to register a number like 20 millimeters, but you need to tell the dental assistant to write down what is the point that you use as a reference point. For example, the top of the mesial buccal cusp, for example. But you need to have that recorded into the file, because if you don't have this information, if you treat, for example, the case in 2 visits, or if you have too many root canals, you may forget some information, and when you ask that information from your colleague, from your dental assistant, maybe she will not be able to provide the whole information so that you know exactly which were the reference points for your measurement. One more comment regarding the working length, because it's not enough only to say just use the apex locator. I want to give you some more details. Of course, you need a good apex locator. I prefer that, not because the other ones are not precise, because I have to tell you that in my whole more than 15 years dental career, I never encounter an apex locator that generates errors. And by error, I mean that the root canal is 20 millimeters and the apex locator shows that it's 22 or 18. That never happens if you use them correctly. But if you use a good apex locator, the difference is that you may find out the working length in 1 second, while with a not so good apex locator, you may struggle for minutes in order to find out what is the exactly working length. And what you really need to know is that no matter what apex locator you use, you need to know this information. All the apex locator in the world measures one single precise length, and that is the apical constriction. If you are, let's say, 1 millimeter shorter and the apex locator shows you that you are 1 millimeter shorter, the truth is that maybe the apex locator is right, but in most situations, the apex locator has no idea where is your file in the root canal, because in the root canal it may be liquid, there might be pulp rests or something like that, and under these conditions, apex locator cannot be precise no matter what the producer writes in the user manual. But what all the apex locators are generating is the apical constriction, the minor apical constriction place. And if you want to work 1 millimeter shorter, please just calculate by yourself what means working length minus 1 millimeter. You find out with apex locator where is the apical constriction, and then just stay 1 millimeter shorter. Of course, we can talk more than 2 hours only about working length, but I've told you that I just want to present you a simple protocol. And if you use that protocol, you will not have surprises. You will not have unpleasant surprises. And we arrive at step number 8, which is actually chemomechanical treatment. And I would not say that this is only the most important part of the treatment, but it's also the longest part of the treatment. Irrigation and instrumentation together represent the longest part, if we talk about time, the longest part of the endodontic treatment. And let's talk about irrigation first. I don't know if you used to ask yourself, why do we need to shape the root canal? Why do we need to enlarge the main root canals? And you have to know that the only reason that we do this is because of the lateral anatomy, because we don't have only main root canals, but we also have lateral anatomy. In old times, what dentists used to do was to use some tear nerve files, and they introduced one tear nerve files in the root canal. They rotated it a little bit. They were looking very, very happily to the pulp, to the nerve, as staying attached to the tear nerve, and they were very happy with what they did. Sometimes they did not even use the irrigant. They were just make the root canal filling. Nowadays, we know that tear nerve are not useful anymore, because we know that the main problem is not the pulp in the main root canal, but the debris and the bacteria and the pulp in the lateral canals. And that's why we use irrigation. It's a long talk about irrigation. I don't want to start it, because probably then Damir will have a very difficult task on the chat. A lot of you will ask questions, and he is very experienced with this topic of dental irrigation. I will only need to say that you need sodium hypochlorite at the highest concentration available. At least in my case, I do not put water in sodium hypochlorite, and I don't put sodium hypochlorite in water. I just use sodium hypochlorite 5% concentration, so the strongest possible concentration. And I can't give you a recipe that how much you should use or how many times you should irrigate. I know that there are some studies, most of them in vitro studies. They try to give us some recipes regarding time that we need to use, but we need to understand that those guidelines are based on information, on in vitro information, and that in vitro information hardly simulates what's going on inside the root canal, because inside the root canal we bring more and more and more sodium hypochlorite. We use ultrasonics. We can heat the sodium hypochlorite, or we can agitate it with ultrasonics, and it heats itself in the root canal. So the problem is very complex in order to be able to investigate it completely. But what we know is that we need sodium hypochlorite in order to dissolve the pulp, and if we use a lot of sodium hypochlorite, we cannot harm the tooth. We never can use so much sodium hypochlorite, then we can damage the dentin to such an amount that we will put in danger the future of the tooth on the dental arch. And now that we know why we are shaping the root canals, let's see how we can improve that. The simplest way, I will not talk about expensive tips for ultrasonics, and I will not talk about lasers, because we will never finish this topic. The simplest, the easiest way is to use the basic ultrasonics. And these ultrasonics are in every dental office. You don't even need to have an endo dedicated device. Of course, if you are passionate of endodontics and you want more, of course you will buy some devices, and you will like to perform some more careful ultrasonics. But on every dental office, you can use what you see in this movie. This is called endo check. Actually is a tip that you can place in any ultrasonic device, and in this endo check you can place care files. You can cut them from the handle and just place them in that tip, in that ultrasonic tip. There are also manufactured tips for this endo check. I prefer the ones that I made in my office, cutting the handle of the files, because this way I can choose as many lengths as possible. I can choose as many thicknesses, if we talk about the tip of the instruments, as possible. And even I can cut with the board the instruments, and I can make them sharper or not so sharp if I don't need something very aggressive. The last thing that I want to talk about this passive ultrasonic irrigation is that always you should try to use it passively. I mean, not having contact with the dentinal walls. Of course, you can use this also as a weapon, against root canal filling if you do a retreatment, or a weapon against calcified canals. But this is another story, and I don't recommend to do this without magnification, especially without dental microscope, because you can't see as good as possible. And now let's talk about the preparation of the root canal. I mean the enlarging. I already told you why we enlarge the root canal. Now I will try to explain you why not to enlarge the root canal too much. You know that in medical field, any treatment, any drug, any procedure that we perform has good effects, but also it has not so good effects. And talking about talking about secondary effects of the root canal preparation, the first thing that comes into our minds is that whenever we touch the dentin, the healthy dentin, with any instrument, burr or file or ultrasonics or anything, we contribute to weakening the tooth structure. And if we do that, the life of the tooth on the dental arch will be shorter than the case when we did not perform that procedure. So please think twice or 3 times or 10 times if you really need to use one more file to finish the procedure. Is that file really needed? Isn't it too thick? Isn't it not so elastic that we need? Is it really necessary to use it? And use it only if you know it's really necessary. And then the second thing that comes into our mind is the smear layer. Because you know that with any instrument, if we talk about burrs or if we talk about files, we generate smear layer. And this is the topic that I like very much, because if we look into the literature, even if it's scientific literature or if it's some literature that it's ordered by some companies that manufacture dental files and they want to show how good their files are, they always talk about the way this smear layer, this debris goes, and there are only 2 possibilities: to go into the pulp chamber or to go apically. Nobody talks about the smear layer that doesn't go not to the apical side and not to the coronal side. And that smear layer, where can it go except the lateral anatomy? And that's the most problem when we do endodontics and we are not very experienced, because we do not realize why we use files and what we should do with those files. We focus on shapes, we focus on enlarging, because we know that in the end we need to deliver a nice root canal filling. But things are not like that. We actually enlarge in order to be able to clean the lateral anatomy. And if we want to do that, we need to be very careful in order not to block that anatomy with a high amount of debris, because if we block the lateral anatomy, then we'll not be able to clean it anymore. And if on vital cases is not so demanding, but on the necrotic pulp, when we have bacteria into root canals, we know that it's very important to also clean the lateral anatomy of the tooth. So this protocol that I started, and I will further on with it, this protocol is a very careful protocol regarding this smear layer in order not to block the lateral anatomy. By the way, you can reach the working length with one single rotary file, and we have nowadays files that can do that in seconds. You take the file, you put it into the root canal, and if you are brave enough, in 5 or 10 seconds, you reach the working length. But that's not endodontics, that's just reaching the working length. if you ask the question, okay, what happened during those 10 seconds? Didn't I create some debris? Where is that debris? For sure, it's not in the pulp chamber. For sure, it's not apically. Most of it is in the lateral anatomy, and that will influence directly your rate of success on the long term. And in the end, I will not talk about accidents. I don't like accidents. And more than that, I believe that if you follow rules, if you follow simple rules, you cannot create accidents. Okay, you can create accidents if the patient moves suddenly and you are with the file in the root canal. And if patient's head moves for, let's say, 10 centimeters, yes, of course, you can create accidents and you can create important accidents. But that's about unpredictable things. If you follow the rules, if you change the files, by the way, I don't know if anybody from Great Britain is here. I think we have colleagues from Great Britain, and not only in Great Britain, they can confirm that root canal files, no matter if we talk about manual files or rotary files, are single-use files. And they are single-use files in those countries from the cross-infection point of view. But this is also good for preventing accidents. Of course, this has a price, and the price is the amount of money that patient should pay for the treatment if the treatment is not covered by the insurance companies. Otherwise, I've told you I don't like to talk about accidents. Let's focus on the first two. Don't play with enlarging root canals too much, because you may weak the tooth and you may block the lateral anatomy if you do that chaotically. If you know what you are doing, then everything will be safe. And now let's see how do we enlarge the root canals. Once again, this is a protocol. It's not the best and it's not the only one. It's based on my opinion that if I put this protocol in most of your hands, you will get almost the same predictable result. And it starts with rotary instrumentation, because we already catheterized manually the root canal. And if we work rotary, then the most friendly rotation, actually it's not a rotation anymore, it's a kind of movement of the files. The most friendly movement of the files that I know at this moment is the adaptive motion that was used to be the patent of Cybron company. You know that the Cybron company does not exist anymore, and that's not really necessarily a bad thing, because it did not disappear for nothing, but it was bought about Care company in the beginning, and now we have this KaVo Care company, even greater company. So everything that you found on the Cybron brand, you can find now under KaVo Care brand, are actually the same products or even better products, improved products, but just brand changing. So this adaptive motion technology comes even from the Cybron times, and it was a revolution at that moment, because somebody was clever enough to adapt a motion that will feel what the dentist does with the file in the root canal. And we know that in conventional rotation endodontics, if we talk about conventional rotary endodontics, we used to play with the torque. This torque means that at some moment when rotating, the files encounter some resistance. And if that resistance that they encounter is too big, then the file will break. So the motor tries to understand which is the amount of this resistance. And if this resistance increases to a critical level, then the endomotor stops, and actually it rotates counterclockwise in order to free the file from the contact with the dentinal walls. Well, what about this adaptive motion technology? This adaptive motion technology is almost the same, just that it does not wait until the situation is so problematic that the file will break. Actually, the motor feels when something changes, when the dentist pushes too hard on the handpiece of the endomotor, and if that happens, then this rotation that you have exemplified in the left diagram changes into, I call it, a pseudo reciprocation movement. And I will explain you why it's that, because on the slide it's called reciprocation. But first, let's see what that means. It means that the handpiece will not stop, but when the motor feels that you push too hard, then it suddenly will rotate counterclockwise. And because this is not actually a complete rotation, it's just a short movement, no more than 50 degrees. And 50 degrees if it's really necessary. If 20 or 30 degrees are enough and the motor calculates that, then it comes back again to rotation. Why did I say reciprocation? Why did I say a false reciprocation, not a regular one? Because reciprocation in endodontics is another kind of movement that actually makes the file rotates counterclockwise. It rotates both sides, clockwise and counterclockwise, but the most important part is the counterclockwise rotation. So if we are talking about this counterclockwise rotation, then we know that this is the one that generates the most debris and that it pushes the debris against the dentinal wall. So we know that this is not so good for the success of the root canal treatment. We know that it's good for achieving faster a nice result, but it's just about speed. So we need to avoid as much as possible the counterclockwise movement. That's why these instruments rotates as much as possible clockwise, and only when needed they rotate for a short period of time. They rotate counterclockwise and then clockwise again. And this movement, from my point of view, is the most friendly to the dentist, to the tooth, and to the file. So what could I recommend easier than this movement if we are talking about average general dentists that need a solution that will work in everybody's hands? That's why, in my opinion, I will always recommend this, especially to the beginners in endodontics, but not only. Then the protocol that I suggest consists in some special files. We will use two kinds of files. On the left side, you have the traverse system. On the right side, you have the TF adaptive system. I will describe all of these files, and don't worry, we don't have to use all of them. These are the files that we can use to solve almost all the cases, but we don't need all these files to treat one single case. And I will explain you something about them, and then I will go to the next slide, and then I will maybe come back again. On the left side, we have the traverse system. This traverse system consists in files that are designed to work with rotation. So no reciprocation and no adaptive motion, just rotation. And we have this shorter file that is called the orifice opener, and we use it in the beginning in order to enlarge the coronal part of the root canal. And then we have these other tools that are called glide path files, and we actually use them to catheterize the root canal until the working length. And remember that I showed you the slide with the catheterization, and I told you that I advise you to catheterize the root canal manually. But if you are a little bit more advanced and you are not afraid to directly catheterize with rotary instrument, you can use these instruments for catheterization. Just take care the instruments should be new. So these are not reusable. Um, Actually, I reuse them in my practice because in our country it is allowed, so we can autoclave them. I'm not afraid that they will break, but I don't use them to catheterize rotary the root canal if they are already used. Otherwise, I can tell you that you can use them maybe in 6 to 10 root canals without breaking any single file. They are very resistant, but please follow the protocol. If you will put all the all your hopes into this file, then probably it will break if you use it several times. But if you respect the rules and if you do manual catheterization first, I will show you in the next slide, then you will never have problems. So we are talking about these intro files, let's say, and we are talking about the files on the right side, which are called twisted files adaptive. And these files are very special files, not really necessary because of their shape or of their material. Of course, the nickel titanium, the alloy is very special, but it's not special, let's say, not special regarding the resistance, but it is quite special because these files are twisted. That's why they are called twisted. Normal nickel titanium files are produced by cutting something from a piece of nickel titanium, while these rotary files called TF adaptive are the only files on the market that are produced by rotation, by spiralation. And if you take that in consideration, you will realize that they are very very friendly also, not only the adaptive movement of the motor, but also the alloy and the way the instrument is made are very friendly with the dentist, because if you do something wrong and the pressure is too high, they will reduce their spiralation, but they will not break in the first time. And you can also use these files in, let's say, 6 to 10 root canals, but taking consideration that one straight root canal, it's not the same with one very difficult with many curvatures root canals. So when you count the uses, the number of uses of these files, please make yourself a fair evidence of the instances that you use the files. And if you had very difficult cases, or if you estimate that you will have one today, it's better that you start with a new set and you will not take a used one. I will come back to this TF adaptive, but first let's see how do we use these traverse files. You can start with the orifice opener. This orifice opener will enlarge the first part of the root canal. And then you can do the catheterization, because you don't work on the whole working length with the first one. So it's not really necessary to use manual files first, but you need to know when to stop, because if you go too further with this one, I mean, if you go further than a curvature, then you can block the root canal. So please stay in the coronal part and in the middle third, but without forcing the file far from the curvature. And then you take the manual files, you do the catheterization as I showed you, and after you used the number 10 file, actually you can start with the traverse glide path files, and you see that you have two files here. You will never use both of them because it's not necessary. You have two kind of root canals. You have root canals that you catheterize very easy, and in these canals you will use the one on the right, because the catheterization was easy, so the canal was large, but be very careful when you use large, because when somebody talks about a large canal, they imagine that only the apical part is large, and when they talk about small canals, then they imagine that the apical constriction is very thin, which is not always the truth. If you have a difficult canal to catheterize, uh, even in that situation, you may have a root canal that is very large apically. The reason for which you catheterize difficultly that canal I explained you in the beginning. It's because of the multiple curvatures, and it's not because of the thickness or or how thin the root canal is. So going back to the procedure, after you do the manual catheterization, either you take the left file, this one for small canals, I mean for canals that are difficult to catheterize. What means difficult? It means that you take number 6, number 8, number 10, you go back to number 6, and it takes some time in order to reach the working length. Then you take the file on the left. This file is 13 hundredths of millimeter in the apical at the tip, and the taper is 0.6. Or if you have an easy root canal to catheterize, then you will take the file on the right, this one with the white line here, and this file is 18 at the tip, 18 hundredths of millimeters, and then the taper of the file is 0.6. And if you manage to bring these two files to the working length, then it's time to do the apical finish part. And you can use one of these sequences that you can see here, mentioning the fact that the one on the top, this called SM, was designed for small canals, what I call difficult to catheterize root canals, and the lower one on the lower part of the picture, which is called ML, it's from medium and large. This sequence was imagined in the beginning for treating the easier root canals, I mean the easier to catheterize root canal. And you have to know that in the beginning, there was only this TF adaptive system. The traverse system came later, and these files were designed to work separately from the traverse system. So when you were having only this system, you were supposed to catheterize the root canal until number 15 file, and then you start working rotary, choosing one of the two sequences. If you combine them with the traverse system, you just need to notice that, for example, this green file from the down part of the picture is not necessary anymore, because it does exactly the same thing that this orifice opener does, as it is 25.8, 0.08. So they are the same, and usually you do not work with them on the whole working length. So if you used this one on the traverse system, you can forget about ML1. And now, if it's a narrow canal, a difficult to catheterize canal, you take the upper one. If it's difficult, if it's easy, you take the lower one. What you also need to know is that these colors, green, yellow, and red, have no connection with the ISO identification, ISO standard that we are used in care files. Actually, these green, yellow, and red are similar with the red lights on the street, and it means that you always use the green file. Sometimes you need the yellow one, and very rarely you use the red one. And you always use them on the whole working length, and you always use them in this sequence: green, yellow, and red. But what is also important, as I've told you, we don't want to harm the healthy dentin. So if you consider that you do not need the whole sequence, you are not forced to use the yellow and the red file. You can stop at the green one. And there are cases when you can stop at the green one, and there are cases when you should go farther than the red one. And if you should go farther than the red one, you will see immediately why I say that. If you should go further than the red one, you have to take in consideration that you need to switch to manual files, because the files are too thick in order to be able to use them rotary anymore. Otherwise, you have the parameters of the files of the TF adaptive system on the right side of the image. What is the most important is the parameters. This is for orifice opener, 500 rotations per minute, and torque 350. And if we are talking about traverse glide path, you see that we use the same speed, but we make the torque lower. Okay, and this is again the TF adaptive. Of course, if you want the adaptive movement, you need the motor, the endodontic motor from the KaVo Care company. Otherwise, you can use these files in rotation, and you have to know that there are some similar files that are called TF. It's not TF adaptive, it's just TF, twisted files. And they were before the TF adaptive system, and they were used rotary. And if you want to use these files on endo motors from other brands, then you should use the settings for TF, for regular TF files. And now let's talk about how we manipulate these files, because this is the most important part. And if I talk up to now about traverse and adaptive, TF adaptive, what I'm talking now, it's about any rotary system. No matter what are the rotary files that you already have or you want to buy, these simple principles apply to every single file system that you use. Even if you use reciprocation systems, just one comment: if you use reciprocation system, just try to be more careful. I mean, to apply these rules even more careful than when working with adaptive or with simple rotation, because I've explained you reciprocation means very high speed, but it also means a lot of smear layer that you have to manage. So coming back to the procedure, the same rule like in the catheterization, you need sodium hypochlorite in the pulp chamber. The pulp chamber should be full with sodium hypochlorite. The only moment when the pulp chamber is dry is when we use the apex locator. Otherwise, when we catheterize and when we enlarge the root canals, the pulp chamber should contain sodium hypochlorite. So, as you can see in this movie, we need to follow some rules. First rule, I've told you, it's liquid in the pulp chamber. The second rule is that the file should be introduced in the root canal while it rotates already. That doesn't mean you have to press the pedal and then take the motor from the table and put it in the patient tooth, but you don't have to push the file while it does not rotate. Don't push it until it engages the dentin and then press the pedal. Just put the tip of the file into root canal, and while it doesn't have contact with the dentin, just press the pedal and then just go further. And when you go further, do only 3 movements in and out. If you look to my hand onto the webcam, you can see that means in, out, in, out, in, out 3 times, and each time no more than, let's say, 2 to 3 seconds. And after you do this for 3 times, you take the file out of the tooth, you clean it in a sponge, You can use a sponge like this with an endo ring, and the dental assistant can keep it on her hand, on her finger, or you can keep it on your finger if you are not used to work in four-hands dentistry, and you clean the file in that sponge. You don't even have to put some liquid in that sponge. The mechanical cleaning is more than enough. And then you irrigate again with sodium hypochlorite, and then you come again with a manual file like number 10, for example. I almost always use number 10, the purple one. And as you can see now in the movie, I do what we call a recapitulation. This recapitulation is meant to take the debris from a possible apical plug and from the lateral walls and bring this debris into the solution. And if you use from time to time also ultrasonics or maybe even lasers, but I told you I want to keep it simple, so ultrasonics are more than enough, then you can be sure that you manage the debris, the lateral debris, as good as possible. So let's say again, you need liquid in the pulp chamber, you need the file to rotate when it's introduced in the root canal, no more than 3 moves back and forth, and you clean the file, you irrigate, and you recapitulate after such a 3 steps sequence. And when you reach the working length with a file, you go to the other one. And now the only thing that I need to say is when you stop. And this is a tough question because actually we do not have we do not have something very precise in order to say, okay, I will stop at number 25 file. I will stop at the taper of, I don't know, 04 or 06. There are no rules. What we know is that we do not need to destroy healthy dentin. And if you agree that we don't need to destroy healthy dentin, then actually what we are doing in the apical third of the tooth is not enlarging the root canal. From my point of view, and what I'm doing in my day-to-day practice is trying to approximate the diameter of the root canal. Of course, I'm aware that the root canals are not round in their section. They have an infinity of possibilities when we are talking about the shape of the root canals in the apical third, but we need to make this approximation because we also use good aperture points to obturate the root canals, and these are also round in section. So unfortunately, we need to do this approximation and to live with this thing that we know the root canals are not perfectly round, but we use instruments and materials that have a round section. And this is the way that I recommend to students and to beginners in endodontics to appreciate when they should stop. I advise them first to work manually and to examine very well the files. And if you carefully look to this file, you will see, I don't know how good is the quality of the image on the screen, but please follow the arrow that I'm used to show. So this part from here to here, that means about 2 millimeters, but not the tip of the file, is engaged in dentin because we have debris. While this part of the tip, also 2 millimeters about, is clean. It didn't have any contact with the dentin. And there are 2 possibilities. One possibility is that I was wrong and I thought that the working length is longer than expected. So this part of the file is outside the tooth, but I pretend I know how to use the apex locator, so it did not happen. So the other possibility is that the root canal in the apical 2 millimeters is thicker than this file. So I will take the next file, but not to enlarge the root canal, because I've told you I don't want to enlarge root canals, but I want to make an idea, an approximate idea about how this root canal looks like and how large is it. And this time, if you look at the second file, you can see that for about 4 millimeters, there is dentin all around it. So it means that this file was active even with his tip. And if I'm sure that the tip was at the apical working length, then it means this is actually the approximately apical diameter. It doesn't mean that the apex is perfectly round. It doesn't mean that if I will take a gutta percha point, I will completely seal the apical constriction, but it definitely means that if I take a gutta percha point and I try to force it farther from the apical constriction, if the gutta percha is similar to this file, the gutta percha point cannot go farther than the apical constriction. And that's the reason of this protocol that I told you. This is the way that you will be absolutely sure that you do not do root canal fillings in the periodontium, which of course we all want to achieve. Also, another example, a file that this time it worked into the dentin, because we can see a lot of dentin on the tip of this file. So this is actually a file that in a vital case, from my point of view, should not have been used. It's too much. I sacrificed healthy dentin. I can even show you examples of the quality of the dentin that we can have on our files. If you look to the images on the lower part of the screen, you can see that we have debris on the files, but you can also see that the color of the debris is brownish. And trust me, that's not blood, because I know what it was in the root canal. Actually, that was affected, that was a bad dentin, and we need to get rid about that dentin. And as far as I can see that color on the files, I continue to use files, not because I'm sure that in this upper right corner this dentin does not contain bacteria. I have no idea if there are bacteria there, or maybe I know that for sure there are some bacteria, because in the end bacteria are everywhere, are in the air, are in the water, are everywhere. So of course, even on that dentin we can find bacteria, but what I can tell you is that macroscopically the dentin in the lower images does not look right. So I need to do anything to clean out as much as I can see, without pretending that if I don't see that brownish color anymore, I cleaned the whole altered dentin. But just I can pretend that I made everything possible not to have microscopically altered dentin on my files. So once again, in order to be clear, in vital cases, we should stop whenever we see something like that on our tip of the instruments, no matter that we talk about hand instruments or rotary instruments. On non-vital cases, we will continue to enlarge, and this time I'm talking about enlarging, not just about trying to approximate the root canal size, the apical size. This time we enlarge until we can see healthy dentin on the file. And now we go to the step number 9, and we are close to finish. Step number 9 refers to root canal filling, and as my colleagues from KaVo Care will let you know, we are going to have another webinar about root canal filling, only about root canal filling, in about 1 week, I guess, or 1 week and something more. I don't know exactly, because as almost all of you, I'm on holiday, so I hardly remember what day is today actually. Thanks God, one colleague remembered us that it's the beginning of the weekend, so I will not forget it's Friday evening. But we will have a presentation just about root canal filling. In the meantime, let me tell you a few things about what I think is the most important. And from my point of view, when talking about root canal filling, it's not a technique. You can see in the right side a movie about vertical compaction. I always try to do this technique, but I don't think if somebody uses the monocone, the single cone technique, will achieve a less successful result. By contrary, I think the success rate will be quite the same with somebody that use vertical compaction if they follow the same rules until this moment. What I want to show you is the X-rays on the left side of the screen, and I invite you to notice that in all X-rays that I placed here, the root canal filling finishes too high. I mean, it finishes in the pulp chamber, or sometimes it finishes on the occlusal part of an abutment or of a tooth, like here. And I'm sure that it oftenly happens to you that you examine a tooth, you start a treatment, and you find, if it's a retreatment, you find gutta percha points immediately under the occlusal surface, which is totally bad, because we know that root canal filling, it's root canal filling. It should stay inside the root canal and not in the pulp chamber, like here or like here. Or I will show you another example and another one. Look at this lower premolar. It's on the occlusal surface of the abutment, and here the same. Look, in the central incisor, you have the root canal filling, you have the gutta percha point actually in the mouth. There is no more root coronary filling there, and you have the gutta percha point in the mouth. Here you can see through transparency that you can even see the gutta percha through the metal of the crowns. And finally, you can see here even individual gutta percha points. I think somebody here tried to do something like a lateral compaction of gutta percha, but the most important and the worst thing is that this gutta percha occupies more than half of the pulp chamber, and that means we do not have enough place for the last step of the procedure, which I think it is the most important step for the future of the tooth. If everything that we talked about up to this moment was about the success of the root canal treatment, now we need that this success will be present in 1 year, in 2 years, in 10 years, and maybe in 100 years. And if we think like that, then we should understand even what I was talking in the beginning. Remember when I was talking about making the lateral walls by adhesion under the rubber dam. The question is that if I practice to use thermoplastic gutta percha filling, what do you mean by thermoplastic gutta percha filling? Do you mean something like thermafill, or do you mean like extrusion of liquid gutta percha from something like Obtura device? So you mean like thermafill? No, I've never used that. I think it's quite a very worm gutta percha. Yes, I use worm gutta percha. I use actually continuous wave technique and backfill technique. But I will talk about yes, I will talk about this in the root canal filling webinar, and we will largely discuss about that topic. So let's come back to this number 10 step, which is one of the most important steps when we talk about long-term success. And I don't have time to debate this subject strongly, but I'm sure that with other occasions, because you have to know and stay tuned, because KaVo Care prepares not only 2 or 3 webinars, but there is a very long list of webinars on different subjects, and for sure this functional tooth restoration will be covered during these webinars. So please stay tuned and follow these topics, because you will find very important information. I will only say what is vital for the success of the tooth. First thing is adhesion. in those days we cannot talk about dentistry without saying the word adhesion. So everything that we managed to do, we managed to do because of this adhesion. Yeah, thanks Damir for commenting. And the second one is cusp protection, because we know that the endodontically treated teeth are unfortunately weaker than the ones that were not touched by the endodontic procedure. So this kind of protection is mandatory. And when talking about cusp protection, just remember these three concepts. You can make a direct restoration, like a filling, a regular filling. You can do an onlay that is made by a dental technician, and you can make a crown. All these restorations should be thought in the way that they protect the remaining tooth substance. And very shortly, I will tell you my preferences. Um, my own preference is the direct filling, and I will explain you why, but not any kind of filling, because it needs to have a special design. I mean, we need to sacrifice the cusps in order to cover them completely with composite. I prefer this method because it's made by me, and when I'm talking about me, it's not like me, Dan Caminescu, but it's about the dentists that treated the tooth, maybe endodontically, and it's the dentist that uses rubber dam. And under no circumstances you can get better adhesion than with rubber dam. Of course, you will say that. Of course, you will say that you can bond onlays and crowns to the structures, but my opinion is that the adhesion that we achieve when making direct fillings, and when we use stratification and on the concepts that we know, we achieve a better feeling, a better restoration, a better way to restore the tooth, a better way to restore the tooth on long term. And I'm saying that because when I want to restore endodontically treated teeth, I need an elastic material, not a very strong one. And I want a material then that when something goes wrong, I mean, when the patient chews or bites or on something which is very strong, and that's an accident actually, I want that the filling will break, or the post, if I decide also to place a post in the root canal, I would like that the restoration will break and not the tooth. Because if the root of the tooth breaks, unfortunately, that means surgery and implantology. And of course, I'm not against surgery and implantology, but we need to know that if we can preserve tooth structures as long as possible without jeopardizing the bone around and the gums and the temporomandibular joint and something like that, then we should do our best to do that. I will not further continue with this because of course, there will be other webinars held by my colleagues on that topic. Somebody asked about C-shaped canals, about filling C-shaped canals. I think the most important with C-shaped canals is cleaning the C-shaped canals, not filling them. Sorry, I will interrupt because somebody asks about laser in endodontics. My friend Damir here is the most experienced guy that I know in lasers. He even visited Romania last year, and he had a workshop about dental lasers, hands-on actually, and I'm sure he will be very happy to give you some more information. I don't know if in one of his webinars, but maybe if you have questions, he can write here some answers. Please, in the same time, please do not go too further from the topic of today. In the meantime, I will talk about this shaping and filling and C-shaped canals. So the most difficult part is shaping the C-shaped canals, and actually not shaping but cleaning them, because they are already shaped. We know it's C-shape, and we know that we cannot do too much with the files in order to shape. So we will base mostly on sodium hypochlorite and a lot of ultrasonics. Sodium hypochlorite, ultrasonics. If you want to add EDTA from time to time in order to dissolve the anorganic part of the debris, you can do it. But remember, it's just about cleaning and less or nothing about shaping. And when we talk about root canal filling, you can do it two ways. You can do it conventionally. I mean, just take 100 good aperture points and just place them there, 1, 2, 3, 4, 5 to the working length. Doesn't matter how many they go inside. Or you can use some method of vertical compaction that I will for sure present in the webinar about root canal filling. But the most important part is that, taking in consideration these root canals are very difficult to clean, are very difficult to fill, and most important, are very difficult to retreat, then do your best to do the best coronary possible sealing, because this way it will never be necessary to retreat this tooth, because this is the most difficult part for most of us. So let's make a very, very short recapitulation. Which are the 10 easy predictable steps easy steps to predictable endodontics? This recipe of successful treatment means this: carefully select your cases. And I mean, when I'm talking about selecting cases, I'm talking about two things: about correct diagnosis and determine if it's an endodiagnosis and the problem of the patient cannot be solved by endodontics. And the second one, very important, decide. You are the best and the only person to decide if you can treat the patient, and you should refer the patient. And if you decide that you should treat the patient, almost always deliver anesthesia, because even from the beginning, when you place the rubber dam, if it's a difficult isolation case, you can create a discomfort to the patient, and the patient can associate even the rubber dam with this pain, and it will be very difficult next to do the other procedures that you need to perform under rubber dam. And then it comes the isolation, and I think I don't have to mention that without rubber dam there is no endo, no rubber dam, no endo. Just remember that. And if you place the rubber dam, try not to use it after making some adhesion on the tooth, because in this situation, unfortunately, and even without magnification, which is even worse, you cannot control the things, and you will fool yourself. You will think that you have there some good adhesion, while in reality it's just something that stays there until some moment, but you will have very soon you will have leakage there. And then regarding the excess cavity, remember, always adapt the cavity to the case, but also to your skills. If you feel that you can control that case and in the same time to be conservative, please be conservative. If you think that that case it's a difficult one, and making a conservative access may jeopardize the final result, never ever even think to do that conservative access, because on short time you can create too much damage to the tooth than you would create on long term if you do a very, very generous access cavity. And then please try to find all the root canals. I know that most of you have a big issue with the MB2 of the upper molars. Actually, that is a very, very easy, difficult canal to find if you follow the map on the pulp chamber floor. And if you find the orifice, which once again, it's not a very difficult task, if you find it, then it comes about catheterization. And I think I gave you all the necessary data in order to address to even the most difficult root canals. You just have to remember that when you cannot go further, just stop and enlarge the root canal until that point without creating a plug. And if you do that, then you will have no more problems in proper catheterization. And when talking about working length, remember, always use apex locator and always look for apical constriction. If you look for something else, you will not do predictable endo. You will do good endo, but your root canal fillings will not be consistently at the length that you expect them to be, which does not mean that you will have necessarily less success, but you will do things unpredictably. You will not feel that you are in control, and you can be very easy in control if you understand that. And when talking about chemomechanical treatment, I only want to say that you always have in mind, preserve the healthy dentin and do everything what you do in order to irrigate as good as possible. Then you do the root canal filling. It's not important what method you choose. I will never choose lateral compaction because I think lateral compaction is a good method, but it takes too much time if you want to do it correctly, and that time does not return so much good results if we compare the effort to the final result. So either you stay in monocone technique and you do it properly, and we will talk a little bit in the root canal filling webinar also about monocone technique. But if you want something more, you can do vertical compaction. I can't say you will be more successful with vertical compaction than with monocone. But what I can say is that with vertical compaction, you will manage to feel more lateral anatomy, with one condition. And we come back to step number 8 again, with the condition that you maintain the lateral anatomy opened. As long as you have plugs of debris, you will not be able to clean, and of course you will not be able to fill. And last but not least, adhesion and cusp protection. If you take care to that, I can guarantee you that you will only have very, very, very few bad cases. You will have a very, very low number of unsuccessful cases, and that will not be because of your procedure, but that will be because, unfortunately, any treatment in this world, any medical treatment also has a success rate and a failure rate. It is already too late. If there are still questions, I will try to answer. Once again, thank you, Damir, for your help. In the meantime, if you want to stay in touch, this is all my available contact data, online contact data. I did not mention in the beginning, I really love face-to-face meeting with my colleagues. I mean, hands-on lectures where we can debate and where we can see each other. But unfortunately, in this period of time, we need to stay only in virtual online. So these are the places where you can find me. Please feel free to write me whenever you have an endo problem. And if you will follow this Facebook page, for example, or if you will follow the YouTube channel or my LinkedIn profile, you will know about other webinars or lectures that I will give for the moment online. And why not when everything will finish, and I hope all of us will be healthy and strong after this period of time. I hope we will also have the opportunity to meet and further discuss. Thank you, everybody. I see that some of you just started to leave the meeting. We are still 200 people are here. Once again, if you have questions, I will be a few more minutes here to answer. If not, you will be in touch with me on the social media platforms. Thank you, everybody. Once again, I am very, very happy because you managed to gather here from so many countries over the world. That's another proof that dentists should stay together no matter the religion or the nationality or even the dental concepts that they agree or not in. And I hope we will have the opportunity to meet again. Darius, special thanks to you for taking care that everything went smoothly on this webinar. Damir, many thanks, because you made my activity much easier with answering so carefully to all the comments. I hope sometimes I will be able to return this favor to you. Thank you, KaVo Care, once again. I like very much that you started to say words in your own languages. It's very nice to be able to read how you can say thank you in your own languages. And why not? I hope that we will meet again as soon as possible. Darius, if you want to mention something more, you have the microphone, please.
It was really impressive, and thanks a lot to all participants that have participated in your webinar. Hear you next time. Thanks a lot.
Thanks a lot, Darius. I will say also goodbye to you officially on the chat. And then I will kindly ask Darius to finish this meeting, but I hope to see you as soon as possible. Josip said that I need a beer after 2.5 hours of speaking. I would be very happy that we will sometime drink that beer together, and not only with Josip, but with many of you, because I know that all of you are wonderful people and that you like not only endodontics, but also a lot of other interesting topics. Once again, thank you very much, and let's meet to the next webinar, which actually will not be my webinar, but I will also be there, and I will carefully look to my colleagues' speeches, because I know all of them, and I know that they are very good and very passionate about what they are doing, and I'm sure that I will have a lot to learn from their speech, and I really want to share that information with you, maybe in comments and so on. Once again, have a nice evening. Darius, thank you very much. Once again, I declare the meeting closed, so you can officially push the button.